So today we are learning about the common gastrointestinal symptoms in palliative care. So most of the time, next slide please. The common gastrointestinal symptoms we come across in palliative care is oral thrush, stomatitis, dry mouth, nausea, vomiting, constipation, diarrhea, and intestinal obstruction. So today we'll be learning in detail about nausea and vomiting. And in the next class, we'll be dealing with constipation, diarrhea, and all other things. So today we'll focus only on nausea and vomiting because it's a vast topic. There are a lot of things to learn to brush up our pharmacological little things. So we'll concentrate only on nausea and vomiting today. So see, around 40 to 70 percentage of patients with advanced cancer has nausea vomiting. We see a lot of patients, not only with cancer, also non-cancer patients whose symptoms are uncontrolled, also present with persistent nausea and vomiting. We are not talking about the acute condition or not solely about the acute nausea and vomiting, but the prolonged, the chronic one the patients are undergoing. So what happens is, in most of our practices, what we do is we have only a few drugs. We only know a few drugs where we are very familiar with, and we write whenever we see this nausea vomiting, we prescribe that. So from this class onwards, you should keep in mind that there are various mechanisms for nausea, and we have to give a targeted drug therapy. It's not like prescribing the same antiemetic for all other causes. So we learn the causes, we learn how it works, and we learn how we are going to give medicines. Next. Next slide. Before. So, why we need to learn about it? Because most of the time it will be affecting the daily functioning and the patient will have a very poor quality of life. Think about yourself. You are having a nausea for 1 day or 2 day. Okay, that's adjustable. But if it is continuing long for a more than for so many days, what will happen? We'll have a very poor quality of life. Also, one other thing that is going to happen is a poor compliance to cancer treatment. See, here we see a lot of patients who are undergoing chemo. But after 1 to 2 cycles of chemo, they'll tell their doctor, I'm going to stop this chemo because this is going to give me a very bad effect. I'll get vomiting, I'll get nausea, I'll feel very nauseated for a very long time. So they'll stop the treatment. So that's what happened. There will be no compliance to the treatment. Another thing is the drugs, analgesics. Sometimes the patient will be having pain and we start the patient on opioids and they'll start having vomiting. They'll stop everything. They'll stop the chemo, they'll stop the taking medicines, analgesics, everything. So that is only going to increase the burden. And there will be, of course, there will be poor fluid and oral intake already associated with the malignancy. Addition to that, all these problems will increase their poor quality, will increase the poor quality of life. Family will also be in distress. Seeing your kith and kin, seeing your father, seeing your brother, seeing them suffering will put them into more distress. So our goal is either to stop. If it is possible, we'll try to stop, or at least we try to reduce the symptom frequency of these problems and to establish a compliance to the treatment. Once the patient is able to take a little food or they are able to take something orally, that will establish a compliance to the treatment. It will enable the analgesic medication and to improve the quality of life. So that will be our goal. So, coming to the topic, nausea and vomiting. So, what is emesis? Emesis is a biological defense mechanism. It's a protective reflex. No, we know it is not a disease. It is only a symptom because of some abnormality. So, it's a biological defense mechanism or protective reflex to remove toxic or harmful substance from the body after ingestion. I have shown the picture of a chameleon who changes its color. Like that, it's our body, the ability of our body to throw the toxic substance out from our body. So it's a protective reflex. Now, there are three phases. Let us explain the phases of emesis. First one is nausea. That is an unpleasant sensation. It's just a sensation of imminent need to vomit. The patient feels that there is something behind their throat or they have something problematic in the stomach. So they feel that's a sensation. Okay, that's the first thing. Now, retching. Retching is a spasmodic contraction of the diaphragm and abdominal muscles against a closed glottis. It may or may not result in vomiting. This is also same in the case of nausea. Nausea, sometimes it's always preceded by vomiting, but sometimes a patient will keep on having nausea alone. They'll not vomit, but they'll tell that I'm having a nauseated, failure alone. Like that, retching is a spasmodic contraction. I know everyone in this group must have experienced vomiting at least once in their lifetime. So remember, when you vomit and you will reach a situation, nothing will come out. You will just there will be contraction. So that is retching. Now the third one is the forceful expulsion. There the gastric contents will come out by the contraction of abdominal and chest wall musculature. And the fourth one, regurgitation, is completely different from this. The food is brought back to the mouth without the contraction of muscle. So that is different from vomiting. Next slide. So the thing is that we need to know what is. I've already explained. It's an unpleasant sensation. Is this either the patient will tell there is, yeah, doctor, there is something in my throat. That can be nausea, or there will be a discomfort in the abdomen. So that may not always resulting in vomiting always. So you should always keep in mind that the patients sometimes will tell only they have nausea or nausea and vomiting. Next slide. So you have to properly document, clarify what the patient is exactly having. Is it nausea or vomiting or retching or regurgitation? For that, you should understand what it is. Now, there are different types. Let me explain a few different types of vomiting. That the first one is acute. Acute vomiting is something which occurs within a few minutes to hours and resolves after 24 hours. Sometimes when we take a food and there is a food poisoning, and sometimes we get within a few hours or minute we get such kind of vomiting. Sometimes of chemo. After when the patient takes the injection itself, they'll start getting vomiting. After that, it resolves. Now, the second type is the delayed, which we see very commonly in radiotherapy department, which usually occurs after 24 hours of chemo, and it will be worse from 48 to 72 hours following chemo. It can last up to 6 to 7 days. So this type of vomiting is very common, and for you have seen right in radiotherapy department, usually patients are prescribed antiemetic for the next 3 days, and this is the reason they'll get delayed type of vomiting. Maybe the first day they'll not be having any problem, but on the following days they'll have. So always by following a radiotherapy or a radiation or chemo, patients can get vomiting. So they are always prophylactically given antiemetics. Now, the third one, breakthrough vomiting. Okay, you have given an antiemetic. A patient had come to you for chemo. You have prescribed antiemetic, and then also he is getting or she is getting few episodes of chemo. That's known as breakthrough vomiting. You have given antiemetic, but in spite of that, also they are getting few episodes of vomiting. That is known as breakthrough vomiting. You have also learned about in pain. You have learned about breakthrough pain, right? So, like that, in vomiting also we can get breakthrough episodes. Now, coming to the fourth one is refractory. Refractory means unmanageable with the current antiemetic. You have given everything, but the patient is not settling. That is refractory. Now, coming to anticipatory vomiting. This one you must have not seen commonly, but this happens in a oncology setting. You know what happened? Some patients who are, for example, a patient is planned for a chemo on Thursday, and suddenly the patient starts getting vomiting on Monday. The family will be very confused. They'll be telling, Doctor, I don't know, is he saying a lie? I don't know what happens. So it happens. That is known as anticipatory vomiting. We'll talk about the mechanism later, but see, there is something like that. So from now on, if some patient come and tell or some bystander come and tell you like this, we see my husband is having this chemo on this day, but he starts developing a vomiting on the day before or day 3 days back. So there is a conditioned response prior to chemotherapy, and that is known as anticipatory vomiting. The patient will anticipate when he gets chemotherapy, and he definitely is going to get nauseated and vomiting. And the thought of that in the cortex causes anticipatory vomiting. Next slide. So now coming to the common causes, what are the most common causes we usually see? This is all these things are very you all will be knowing better. Chemically induced nausea that comes like drugs like opioids, antibiotics, cytotoxic drugs. Then coming to toxins, food poisoning, ischemic bowel, gut obstruction, metabolic organ failures. All these things are chemically induced nausea. Now coming to gastric stasis, anticholinergic drugs, opioids, ascites, peptic ulcer, gastritis, all these causes gastric stasis. There will not be a peristaltic movement, and the patient will have every time they'll have a fullness in the stomach and they feel like a nausea, and sometimes they can even vomit. Stretch or distortion of the GI tract like constipation, intestinal obstruction, and mesenteric metastasis. Then serosal irritation like liver mets and ureteric obstruction, irritation of GI tract. All these things you have, it is very common, right? Infection. So drugs like NSAIDs can cause gastric irritation and that can cause nausea. Now see raised intracranial pressure like patients having cerebral edema, space occupying lesions, IC bleed. They are also present with nausea and vomiting. Movement associated are motion sickness like vestibular disorders, motion sickness. All these can cause uh, problems. Anxiety induced is the one I told the patient, the anticipatory vomiting, as we already discussed. The thought of getting chemo can they anticipate and they can get nausea and vomiting. Now, we're going with the management. So we'll go for first initially, we don't jump into the tablets. We always try for non-pharmacological measures, which are very important. Few things you have to keep in mind. And then we go for pharmacological management. So the non-pharmacological techniques include avoiding foods which precipitate nausea and vomiting. Then a calm and reassuring environment away from the sight and smell of food. Most of the time, our patients will be telling, like, doctor, the smell or sight of food, I don't like food. That the certain food they'll feel irritated. So try to avoid it. Don't force them to eat that only. Try to avoid. Maybe they'll tell like the smell of whole food is causing me the problem. Try to avoid this thing for a while. Don't when the patient is nauseated, never ask them to forcefully feed the patient. Now you can give a fresh air, open air, nurse in the upright position. You can ask the patient to sit and eat. And the last one, the control of malodor. That is very important. Okay. We have a lot of patients who are on colostomy, and very oftenly we hear that. See, sometimes for some patients they'll be not knowing the smell, but most of the time they'll be telling like I can smell when a patient is having. Imagine they can feel the smell, right? A patient having colostomy due to the bad odor, they cannot eat. Or when the patient is having a tumor, an ulcer, which is very foul smelling, how can they eat? We have to consider that. We have to make necessary arrangements or we have to do the wound management properly to avoid smell in that patient. With the smell, we cannot ask the patient, no, no, it's okay, that's okay. The smell is there, but you have to eat. No, no, they can't eat. First, you have to understand that. So, there should be a control of malodor. Now, next slide. And the dietary modification. This thing also you should explain to the caregivers. You should tell that you can give for small frequent meals, mouthful of meals, small frequently, not like giving a bulk of food at a time. So you should always go for small frequent meals and avoid fatty, sweet, spicy food and carbonated drinks. Most of them will not be taking all these things, but still you should enforce that. And especially the third one, which is a very important one, no force feeding. Okay. Tell them to explain to the caregiver about this. Next one. Now, coming to the pharmacological measure, we are going to a little bit about the pharmacology of antiemetics and how does it work. So, listen carefully. Okay, pharmacological measure. So we all know that in the brain, for everything to happen, our brain should control, right? Even a small movement to happen, our brain is the responsible one. So we have a vomiting center in the medulla of brain. Okay. So the vomiting center itself will not act. It needs to be stimulated by different stimuli, and different stimuli acts on the vomiting center, and the vomiting reflex is made. Okay, so the medulla, vomiting center is present in the medulla. Now, where are the different stimuli? We told about so many causes, like in the previous slide, we already know the causes. But the main areas from where we get the stimuli are one from the peripheral area, like gastric mucosa and other parts of GIT. That is the first one. So we get stimuli from peripheral areas and central area. So I'm talking about the peripheral area where when we take drugs or when we take food, the gastric mucosa is involved and also the other parts of GIT. Second one, the sensory stimuli. We get two sensory stimuli from the cerebral cortex, the sight, the smell, like all the things are controlled by the cortex. And that can in turn stimulate the vomiting center. So that is a cerebral cortex. That's the second one. Next one, the very common, the vestibular apparatus. That is the third one. Vestibular apparatus is stimulated during like when you're traveling and all, and that in turn stimulates the vomiting center. And finally, the chemoreceptor trigger zone (CT) set, and there is no blood-brain barrier in the CT set. We know that. So CT set is also a very specific sender where so many things can directly stimulate CT set. CT set in turn stimulate the vomiting center. Right? Next slide. So this is a representation. This is a small representation you have to keep in your mind. See, you have the GIT and everywhere, receptors are there. So receptors play a main role in the pathway. So let me tell you the four parts where you get GI tract from the cortex, from the CT set and vestibular system. See, in the GI tract, you have 5-HT3 receptor, serotonin receptor. 5-HT3 is serotonin. D2 is dopamine. NK1 is neurokinase. So we'll talk mainly about the serotonin and D2. See, you have a GIT and you have this receptors. First, in the slide, please try to remember the receptor. Now, cortex is there. Now, the CT set, CT set, you have so many receptor. Chemoreceptor trigger zone. It's a zone. Zone has a lot of receptor. You have D2 receptor, 5-HT3 receptor, mu receptor, neurokinin, H1 receptor, histamine receptor. So everything is there in the CT set. Now coming to the vestibular system. Look at the vestibular system. You have two receptors there. M1, muscarinic receptor, and H1, which is a histamine. So this picture should be in your mind. You should have a photographic memory and you should at least remember this picture. That is from where you get different stimuli. So now we'll go one by one and we are going to treat the cause. What is causing the problem? And we are going to give an antidote for that. Next slide. So, what happens in the GI system? What happens when a patient takes a chemo or radiation? What happens? The patient will get a tissue damage when you take a chemo or when you take a radiation. It goes to the gut, it goes to the gastric mucosa. There will be tissue damage. From the enterochromaffin cells, serotonin will be released. See, it induces a release of serotonin from the gut wall, where in the gut we have serotonin receptor. So the released serotonin from the gut mucosa will activate the 5-HT3 receptor, and this in turn sends vagal afferents and stimulates the CT set. Understood? It can also, this serotonin has a property to stimulate the receptors, 5-HT3 receptors are present on the CTZ, right? So this afferent nerve fibers will stimulate the CT, 5-HT3 present on the CTZ also. Also, it can directly stimulate the CT cell. Thereby, from the CT cell, they'll stimulate vomiting center and results in vomiting. That is why in chemotherapy patient, you get vomiting. So, who is the person responsible for causing vomiting in patients taking chemotherapy? Serotonin. So, we have to block serotonin. And next slide. And then we give cetrons. For blocking serotonin, we give cetron. Example of cetron is ondansetron. The commonly one we use is like emicet and all we use it, right? Ondansetron, granisetron. Granisetron is long acting, but we commonly use ondansetron. So now think back your oncology department. Usually, when the patient is given chemotherapy, they are usually prescribed antiemetic for at least 3-4 days. We know that the patient will get vomiting. So, which drug is given? We give a anticetron, that is ondansetron, because serotonin is the one who is causing problem there. Understood? Next slide. Now, coming to the next setting, a post-operative. A patient is getting post-operative nausea and vomiting. What happened? During the time of surgery, the surgeon must have given opioids like fentanyl or morphine for controlling pain. So all these things will stimulate. Here comes the D2 receptor. Okay, they stimulate the D2 receptors in the CT cell. We know that CT cell have a lot of receptors. One is 5-HT3, D2 receptor, mu receptor, NK1 receptor, and H1. So see here who is making the problem. The opioids acts on it will act on D2 receptor and mu receptors. Okay, so it can result from the CT set. CT set will send impulse to vomiting center and thereby it can cause vomiting. So who we have to block here? We have to block the dopamine antagonist are given. That's why we give metoclopramide or domperidone and haloperidol. Haloperidol is a D2 agonist. Haloperidol is also a D2 agonist. So this is why in post-operative patients, although patient can get nausea and vomiting, and we always see the commonly perinom. We give a patient with a post-operative vomiting, we can give perinom, right? This is the reason because there is stimulation. We know that opioids act on the mu receptor, and the mu receptor agonist is haloperidol, right? So we can either give metoclopramide or domperidone or haloperidol. So just remember this. Next one. Now coming to the vestibular apparatus. The patient's vestibular system is stimulated and there will be lot of release of histamine. So what can we give here? We can give either antihistamines. If you give ondansetron here, will it work? No. For vestibular apparatus stimulation, we have to give antihistamine because histamine is causing the problem. That is the importance of knowing the cause of nausea vomiting. Okay. We can also give anticholinergics here in vestibular. Both M1 and H1 is stimulated in. Both muscarinic and histaminic receptors are stimulated in the vestibular apparatus. So you can give antihistamines and anticholinergics. Basically, can give antihistamines. Next one. Now, the cerebral cortex. Look, in cerebral cortex, the taste, smell, sight, and memory of something bad can directly stimulate the vomiting center from the cortex. Remember the picture, that picture of brain. From the cortex, it will send stimuli to vomiting center and it can cause anticipatory vomiting. So this is the cause of and the cause of anticipatory vomiting is the impulses from the cerebral cortex. In this situation, can you give emicet or can you give metoclopramide? Will it help? No. A patient complaining to you, he's getting chemo on this day and he's getting anticipatory vomiting.
So you are giving
Can you give on like ondansetron there? No. Here it is anticipatory vomiting. Here who is going to help? Benzodiazepine can help. So we give the management, the treatment for anticipatory vomiting is usually benzodiazepine. We'll discuss it. But see, the cause is different. I'm trying to explain that at different points, the cause of vomiting is different. That is how the management differs. Okay. So here the cause is the stimuli from the cerebral cortex. So the treatment is different. Okay. Next one. So, in short, when a patient is getting chemotherapy or anesthetic drugs or opioids, it can stimulate the chemoreceptor trigger zone where they have a lot of receptors like dopamine, 5-HT3, mu receptor, neurokinin, and histamine. So, we can block these many things and we can prevent vomiting. Okay. Next one. And in short, the smell, sight, taste, fear, and all cortex, the fear of getting the chemotherapy, the vomiting center is stimulated, and there we can give benzodiazepine. So, the drug of choice for the management of anticipatory vomiting is benzodiazepines like clonazepam, alprazolam, lorazepam, and all. Okay. Now, next one. Next slide. Same thing, when the small intestine is from the small intestine, they have the 5-HT3 receptor which is stimulated, which sends the impulse to the CT set where they have again serotonin receptor, and that in turn causes vomiting. When a patient can get chemotherapy, there is tissue damage from the enterochromaffin cell, serotonin is released, serotonin receptors are present in the gut and also in the CT set. So we give a block, anticentron, ondansetron to block both these sides, right? So this is a classification of just receptor. I'm just showing the examples. We already know this. M1 receptor blocker. We give hyoscine, dicyclomine for motion sickness. Avomine, very, very common, right? H1 blocker is antihistamines also we give in this vestibular apparatus problem. Promethazine, diphenhydramine, cyclizine, all these are commonly used. Dopamine receptor, D2 antagonist, metoclopramide, domperidone, and serotonin receptor 5-HT3, cetrons like ondansetron, granisetron, neuroleptics. Neuroleptics are like haloperidol. Example, very commonly used. We'll talk about it. Chlorpromazine and haloperidol. Substance P receptors. Examples of antiemetics are aprepitin and rolapitin. They are newer drugs. That's not very commonly used. Next slide. So this is the in short you have to this is a simplified version. It's little difficult. What we have already explained. See the first one, higher cortical center, memory, fear, benzodiazepines. The next one, chemotherapy, anesthetic opioids, where the CT is stimulated. Again, the vomiting center and vomiting reflex from the stomach. The chemotherapy surgery and all, it will block the 5-HT3 antagonist. And lastly, from the labyrinth, the histamine antagonic and muscarinic antagonist. This is the like the summary of what we told now. So the different stimuli, again, what and all is triggering? We know that chemoreceptor trigger zone have a lot of receptors. So what and all things stimulate this? First one is the drugs, like very commonly are opioids, right? And opioids acts on the mu receptors of the CT set directly. We know that there is no blood-brain barrier at the level of CT set. So this drugs, toxins, like when the patient is having renal failure, when there is hyperuremia, or when there is a liver failure, all these things will directly affect the CT sets. That's why a patient in hepatic failure, patient in sepsis, all the toxins will be produced. Hypercalcemia, all these things directly affect the CT set. So the drug of choice will be something which directly block the CT set. That is haloperidol. We'll talk about it. why say like so? You have to know. See, this is very important. Chemoreceptor trigger zone is stimulated by certain things like opioids, chemotherapy. Already we know. Then our renal failure, liver failure, hypercalcemia, our toxins, sepsis, and all will affect the chemoreceptor trigger zone. Also, in the vestibular system, sometimes tumors can affect. Opioids can also stimulate the vestibular system. Cortex is we already told the anxiety, anticipatory vomiting, association of ICP, raised intracranial pressure, that can affect the cortical pathway. Now coming to the periphery like GIT, where we get radiotherapy, chemotherapy, and GI irritation. So these are the stimuli of vomiting pathways. Now, you now know about the pathways, little bit about the pharmacology, everything and all. So when you prescribe a drug, it should be according to the patient's condition and preference. You should not always tell the patient, see, you have continuous vomiting, you should be on IV, you should be given only intravenous route, nothing like that. If the patient is able to take anything orally, encourage him to take tablets also orally if he is tolerating it. So oral route is the best and the easiest thing. Don't never like force a patient that you have to take a IV route and nothing. There is nothing like that. Okay, but if the vomiting is severe, he cannot take anything orally. He's vomiting out everything. He's not even to take able to take a single spoon of water. Then we can advise him to give IV route. Suppository, sublingual, transdermal patches are also available, but that's not very commonly used. Okay, so oral route is the best and easiest. Encourage the patient to take it like that. Next. So here comes our key point. Treatment should be always based on mechanism and it should not be generalized. Okay, I'm stressing on that point again and again. Next. So we know that already we have studied few drugs or drugs causing nausea and vomiting, which is a very common drug in our setting which causes vomiting, nausea, vomiting. Can anyone tell? In a palliative care setting? Which drug?
Tramadol.
Yeah. Yeah, opioids. Opioids, right? Yeah, morphine, tramadol, fentanyl, anything can cause this thing. So there, what happens? There is a direct activation. All these opioids will act on there is a direct activation of CT cell. Now again, drugs causing gastric irritation, NSAIDs, right? NSAIDs like diclofenac, like ibuprofen. All these can cause gastric irritation and cause vomiting. Gastric stasis. All these, so the drugs causing gastric stasis can cause vomiting. Next slide. So see the biochemical causes. Here, when the patient has a uremia, hepatic failure, ketoacidosis, hypercalcemia, toxin, where is this away? There is no blood-brain barrier and it will go directly to the CT cell, right? Don't forget this point. And coming to the other point, raised ICP. So here, it is little different. A patient having a malignancy in the brain or patient is having raised ICP due to some other space occupying lesion. What is the cause of vomiting here? It is because of intracranial pressure. There is increase in pressure. So if you give ondansetron, will it help? No. If you give benzodiazepine, will it help here? No. You have to do something to reduce the size of the tumor. That is the only method to reduce the intracranial pressure, right? You have to do something to reduce the size. There, someone is very helpful. Who is that? Steroids. Steroids are potent anti-inflammatory agents. So everywhere, wherever in your body, when you have a cancer, when you have a malignancy, you get a peri-tumor edema around the malignancy. Like that, in our brain, when patient get a tumor or a lesion, they'll have a peri-tumor edema. So by giving steroids, it will be very helpful. The steroids will decrease the peritumor edema and thereby at least decrease the size of the tumor a little bit, and the pressure in the brain decreases, and the patient can be relieved from nausea and vomiting. So see here the cause of vomiting is different. Understood? So when you suspect a patient with brain malignancy, or the patient himself is having a brain malignancy or an IC bleed, or when there is a raised pressure, you can go for steroids. The commonly ones used is dexamethasone, which is longer acting, which is potent anti-inflammatory drug and which is very helpful. So you can go for this. Don't go for the generalized antiemetic like ondansetron and all. You can go for steroids. Tell them, explain. Most of the time, most of the people will not be thinking about all these things. That's why I'm stressing on this. Okay. Also, you can ask the patient to undergo a radiotherapy if it is possible. By giving a radiotherapy, the size of tumor reduces. That is the cause of the problem. So when you treat the cause of the problem, it will be easier to achieve. There will be a good control of the symptom. Next slide. So also anticipate the need while starting morphine. So that here what we are going to tell is whenever you see a patient with vomiting, sometimes we'll tell them, see, when you get vomiting, you take one tablet. Is that correct? No, you have to prescribe round the clock medication for the patient. You have to anticipate the patient can get. After chemotherapy, we don't write and give take one tablet when you get vomiting. Not like that. You have to give the adequate dose and you have to give the regular dose. You can give regular dose at least for 3 days. What's going to happen? The patient will have a good control. Giving PRN dose is not that good. Okay. The patient will not get a good control. Okay. So anticipate the need while starting. No, while starting morphine, we write two things along with morphine. One is laxative, right? To prevent constipation, we give laxative. Like that, whenever you prescribe a patient morphine or any opioid, you have to give an antiemetic for at least 3 days. That we are by that we are anticipating to prevent vomiting. And use anticipate alternative routes. If the patient initially he was taking oral medication, but later your the patient is deteriorating, and patient is deteriorating, and later you have to switch to other routes. That is acceptable. Okay, so also the next one, combinations if necessary. That is a very important point. Sometimes you may require more than one antiemetic. You give one antiemetic and you're understanding that the vomiting is not controlled. You're given a proper dose and everything, and still the vomiting is persisting. The cause is little different. You can add a combination of antiemetic is always also permissible. Okay, next slide. So now we are going to a little bit detail about each drug. Okay, dopamine antagonist, antihistamine, anticholinergic, serotonin antagonist. We'll discuss one by one. So coming to the first one, metoclopramide is it's a very good drug because it acts by three different mechanisms. So first one is the D2 antagonism and 5-HT3 antagonism at higher level. Okay, when metoclopramide in higher level, it has a property of 5-HT3 antagonism. So it has two methods. And the third one, which is very important one, is the cholinomimetic action. It acts as a prokinetic agent, induces peristalsis and pushes the gut forward. See what happens when we take a opioid. When you take a opioid, there will be gastric stasis, right? So you can definitely use this drug, metoclopramide, because first of all it has an action on the receptor. Next one is it has action on the gut. It induces peristalsis and push the gut forward. So the dose comes from 30 to 120 milligram. See, it can be given up to 120 milligrams. but you have can start with 10 milligram TDS prophylactically. Okay. So at very higher doses, it can cause extrapyramidal problems. So the maximum dose we advise is 30 to 120 milligrams per day, and it acts for around 6 to 8 hours. And the next one, next slide. Haloperidol. Talking about haloperidol is a drug which we use very commonly in our setting because it has a lot of properties. You know, it is a D2 blocker, and it's, you know, that antipsychotic. It's an antipsychotic, right? Haloperidol. But still, we can use it for controlling vomiting. The drug of choice for morphine-induced vomiting is haloperidol. Can give either metoclopramide or haloperidol because this haloperidol have the property to directly act on the CT cell. So see, chemical causes, we already told so many times, the uremia, renal failure, hepatic failure, acidosis, all these problems causing, for all these problems, when they are causing vomiting, you can give haloperidol. You can give haloperidol for vomiting caused by these agents. Okay? Now the dose is 1.5 to 5 milligram per day. See, you can give up to the maximum permissible dose of haloperidol is nearly 20 milligrams per day. But for vomiting, it is 1.5 to 5 milligram per day. So when you patient start a patient on morphine and the patient is getting patient is getting vomiting because of morphine alone because of morphine, you can give a single dose of haloperidol. Very commonly, we use metoclopramide because metoclopramide has a lot of other actions also. But if you think that the patient is having vomiting only because of opioids, then you can give haloperidol. So the thing that should strike on your brain is haloperidol acts directly on CT. Opioids also acts on the brain, CT. Okay. So every time we have to document the likely causes. It is very difficult to tell that this is the cause for this vomiting. We cannot tell like that. So we should, like, every time we should always have a differentials like gastric, whether it is because of gastric stasis, intestinal obstruction, biochemical cause, drug. And if you give a tablet and if it is not, like, if the medicine is not responding, then you should think you should cut down the diagnosis, provisional diagnosis, or the differential, and you should change. Okay. So when you suspect, when a patient is having certain problems vomit, nausea, or vomiting, you have to document all those things because we cannot tell. All these things happen in our brain, and we can only assume that, yeah, this happened because of this. So uh, always maintain a document, when you document it properly, like what are the causes, and rule out each cause. Okay. Now, these are also very important causes. See, a patient in severe pain, a patient having very severe pain, he can get nausea. And because of that nausea, he can get vomiting. So, when the pain is not controlled, when the patient is having uncontrollable pain, he can have it. So, there, if you give another drug, it will not affect. You should control the pain first. These are few correctable factors. When infection is when patient is having septicemia or something like that. It can affect the CTC and can cause problem. You can control the infection. These are correctable methods. Cough. When a patient is continuously coughing and they can get at the end after a big episode of cough, a long episode of cough, the patient eventually vomits. You can control the cough. Hypercalcemia, it can be controlled. Anxiety, it can be controlled. Very commonly, constipation, even if it is written in the last, it is very common. Patient having constipation due to any obstruction or something like that, intestinal obstruction, they can get vomiting. So these are all the correctable factors. So you have to think about this. A patient having severe pain, you give a patient having a vomiting due to severe pain, you give ondansetron, it will not work. So think about the cause. So again, the most appropriate based on the receptor, write the stat dose, Write the regular dose and write the SOS dose. Not give only the stat dose. Not give only the regular dose. You have to give a stat dose to control the problem at that time. Have to give a regular dose, and in between that, to prevent the breakthrough vomiting, you can give SOS dose. Okay, you can give, when you start morphine, you can give regular dose of morphine 10 metoclopramide 10 mg for 3 days. Along with that, you have to ask the patient, see, even if you take this, you will get vomiting. At that time, you can take SOS dose. Okay. Choose parental route of continuous vomiting, and sometimes a patient will have, even if you give anything, that will not be controlled. Okay. And sometimes we have to go for continuous subcutaneous infusion, IV or subcutaneous. Continuous infusion. You have to set the drug in the pump and you can give continuous infusion to control it. So, like I told, a single antiemetic may not be adequate. For example, in raised ICP and uremia, you can give a combination of dexamethasone and haloperidol. Nothing like you have to give only antiemetic, but always keep an eye like what is the, you have to think why the second one is added. You have to give the first one in the regular dose and the regular way, then only. And if it is not working, for as an adjunct, you can add one more. So, in short, you have to see when the patient is having drug-induced vomiting, drug of choice is haloperidol. Haloperidol is given as 1.5 milligram or 2.5 milligram HS at night dose because it has sedation, and or as BD. For radiotherapy, we know that it is ondansetron. You can give 8 milligram stat and 4 milligram TDS. Chemotherapy, it is the same ondansetron 8 milligram and 4 milligram TDS. Along with that, you can give dexamethasone. Okay, next slide. Metabolic causes, we already told. Chemical induced, like the chemical induced metabolic problems like uremia or hepatic failure, all those things, haloperidol is a drug of choice. For raised ICP, who is going to help? Dexamethasone in higher doses. We can give up to 8 to 36 milligrams IV OD once in a day in the morning. Delayed gastric emptying, the drug of choice is metoclopramide because it has a prokinetic effect. We can give up to 10 milligram TID or QID. For gastric irritation, you can give PPI, it's not PI, PPI, and stop the irritants. So, opioid-induced vomiting, there are different mechanisms. CTS is involved. The opioid can directly act on the CTS. It can see where opioid not only acts on the CTS, it has action on different places. So, increased vestibular activity, it can cause gastric stasis, constipation, everything. This is the reason why patient taking opioid is getting vomiting. There are so many things. Okay, so here the drug of choice is either you can give metoclopramide or one dose of haloperidol, prevented with initial antiemetics like metoclopramide TDS. Anxiety, for anxiety induced vomiting, you can give benzodiazepine, can give either lorazepam or clonazepam. Lorazepam 0.5 mg to 1 milligram as HS, or clonazepam we can give 0.25 or 0.5 milligram HS. So the thing is not like giving and sending them away. Reassess them after 24 hours. If required, adjust the dose or use combination. Most of the time, 1/3 of the patient might require combination drug, and revert back from oral to oral from palliative symptoms also. It's not like if you're continuing IV, you can only continue IV, nothing like that. And the patient is able to take food, convert from IV to again oral. Okay. Next. Thank you. And I think I have told many points multiple times, and that is for you to understand it better and not to confuse. I have told so many points so many times. In one point like multiple times. So if you have any doubts, it's a little bit confusing, and you have to read again One more time, you have to read this, then only you will be able to understand more. After hearing one time, nothing will be like going to your head. So read it. Okay. Thank you, Dr. Nayana, for that wonderful presentation on GI symptoms, especially on nausea and vomiting. Participants, if you have questions, you can post in the chat box, or you can raise your hand and then unmute and ask. Maybe for the next 7 minutes, we can take up the questions and then move with the case presentation for today. I think there are a few questions already in the chat box, right? Yeah, there was one question from Dr. Dilip. So, will mannitol help in cerebral edema, especially when we were talking about the peritumor edema, and you had mentioned about corticosteroids there? So, Dr. Dilip was asking, will mannitol help? Would you like to add your insights to that, Dr. Nana? Yeah, mannitol will definitely help. Along with that, only we told about the steroids. Mannitol is very commonly used now for controlling for patients with cerebral edema, all those things. Along with that, steroids will also help. Steroids also have that property, not only mannitol. That's what I do. Mannitol will help. Any more questions? This being a difficult topic, I want you all to ask your questions right away because we have Dr. Naina here. So make use of the opportunity if you have anything in your mind. So there's one question. Dr. Ravindra is asking in morning sickness, which receptor is involved? For morning sickness, mostly we give it is mostly and like M1 and H1 histamine receptors. We commonly give that antihistamines. Ondansetron is also given. It is not like for this one, this receptor is involved. These are the common ones. Okay. Morning sickness, as Dr. Naina mentioned, the most common drug that most of the doctors used to prescribe is ondansetron, and especially during pregnancy, I've seen many doctors giving only ondansetron, considering the safety of the patient as well as the baby. And that's the main reason why ondansetron is opted. But as Dr. Naina was mentioning, the drug of choice for chemotherapy-induced nausea vomiting is ondansetron. So that we should understand. But most of the times, as she was repeatedly mentioning very clearly that based on the etiologies only you have to go with the treatment and don't go with some empirical management, because there are many studies which say that the empirical management is not very helpful for managing patients with the GI induced symptoms like nausea and vomiting. When we go with the right management, the right receptors that are involved by blocking them, definitely that helps a lot in managing patients with nausea and vomiting. I hope that helps. And Dr. Naina, would you like to add your points? Nothing. Okay. Anything else? Or else I think we can move with the case presentation for today and then take up questions at the end of the case presentation. Right.
Can I start?
Yes, yes. Please go ahead.
Good afternoon. My patient is 45-year DM with
Dr.
next.
Manjusha, we can't hear you clearly. Can you be a bit more clear? If you have some networking difficulties, you can switch off your video. It's not a problem.
Okay. Can you hear me? Can you hear me?
Yes,
Hello.
yes, yes. Go ahead.
My patient is 45-year-old female. Uh, a case of DM with CA colon stage 4. Next. Presenting complaints for nausea and vomiting on and off like since 2 months, and constipation on and off since 2 months. Next. History of illness. She's a known case of DM with CA colon stage 4, diagnosed 5 months back. History of nausea and vomiting on and off. History of multiple episodes of vomiting since last 1 week and decreased oral intake. There was a history of constipation. Patient had several admissions for above complaints in tertiary hospital and PHC. Next. On examination.
Antihistamine ഉപയോഗിക്കാം മറ്റേത് ഉപയോഗിക്കാം.
On examination, patient was conscious, oriented, thinly pale, temperature 98.2, pulse was 82 per minute, BP 100/60. Systemic examination was normal. Next. Investigation, HB was 10, total counts were normal. RFTs, blood urea was 33, serum creatinine 1.2, LFTs was slightly raised, bilirubin total 1.4, direct 0.8, SGOT 59, SGPT 60, total protein was 3.5, ALP was 99, albumin globulin ratio was 1.2, RBSL was 167. Psychosocial aspects. She's 45-year-old patient living with her two sons. Patient was working previously as a housemaid. Now she can't go to work due to her illness and she's upset about that. She has to stay at home and can't go out. She can barely manage to do her daily activities due to weakness, and no one is there to help her out as both sons goes to work. Her both sons are working as a laborer and they face financial problem. Next. When she was admitted, she was given ondansetron 4 mg IV 8 hourly, injection pantoprazole 40 mg IV BD, IV fluid at the time of admission, and she was discharged on oral medications, oral ondansetron 4 mg TDS and pantoprazole 40 mg OD, on syrup lactulose 20 ml at night, and she was taking tablet metformin OD for DM. Mixed. Her main concern was vomiting and constipation and her financial issues. Next. Summary, 45-year-old female with DM with CA colon, stage 4 with vomiting and constipation. Discussion points. What are the problems faced by this patient? How we will treat vomiting and constipation in this patient? Thank you.
Thank you, Dr. Manjusha, for bringing that wonderful case for discussion. So now I open it for discussion for the participants. So participants, you can post your comments, suggestions, and modifications in the management. Because now you have heard the entire session on nausea and vomiting. So here we can see that the main patient story is concentrating more on nausea, vomiting, and constipation. So you can post your suggestions and modifications in the chat box. And meanwhile, I would like to reiterate this question back to you, Dr. Manjusha, because now you have heard this session. So I want you to add your inputs on how you could have managed this patient and what are the causes you think that might be the reason for this vomiting and the constipation, which has been on and off for the past 2 months. And then when you start with this, then Dr. Nayana will be adding her inputs also. Over to you, Dr. Manjusha.
Yes, ma'am. This patient had a multiple admission for same complaint, so probably the cause was obstructions or intestinal obstruction or the because of constipation, and we had only given her ondansetron and pantoprazole, and when it was not controlled by that, we had referred patient to a tertiary center. So probably the cause was because of obstruction.
Would you like to comment on that? Would you like to post your insights on that? Okay, so Dr. Ravindra says metoclopramide can be added to rule out obstruction. Anything else?
First, we have to do something for the constipation because
Okay.
patient may be the cause for the vomiting.
Yes, yes. And Dr. Abhishek says tablet bisacodyl 5 milligrams for constipation. Okay. Anything else? So, Dr. Anna, would you like to add your insights? Yeah, few things I have to stress here is the patient is having CA colon, right? So, in such kinds of patients, we have to always suspect, like somebody has told, there are chances that patient might be getting a obstruction, but it can be a complete obstruction or partial obstruction. We learn in detail about the obstruction in next class. But see here, the problem is because the feces are not moving. Maybe there is no peristalsis. So, like we have already told, the metoclopramide, which improves, which is a prokinetic agent, can help instead of giving an that ondansetron. When if metoclopramide was given, if it was a partial obstruction, it would have helped. If there is complete obstruction, the patient might get pain. That is a different story. But still, we have already not told like there is a complete obstruction. So we can definitely add metoclopramide for this patient. Also, yes, there are some small causes like constipation. Yeah, that has to be corrected. They all are correctable factors. So like that you can manage. Also, if you are suspecting that there is something obstructing, like we told, dexamethasone can also help. Dexamethasone, if there is a malignancy in the alimentary canal and there is a peritumor edema, and if you are giving a dexamethasone, it will reduce and thereby at least will increase the lumen, size of the lumen. Okay, so that can help the patient to relieve the problem. So all these things can help. Any questions? Any comments?
There are a few other comments in the chat box. So Dr. Abhishek says glycerin suppository. Dr. Raisa says doing a PRES. That is very, very important in such patients because when we do a parectal examination, only then we will arrive at a conclusion of what has happened. So yes, definitely. And based on the findings of parectal examination, either you can go with an enema or a suppository and then give a laxative orally. Because here we can see that in the scenario, this patient was having constipation also on and off. So Dr. Ravindra mentions octreotide. Yeah. So octreotide basically to reduce the secretions, we can give octreotide. Yes, that helps mostly in cases of bowel obstruction. And the cheapest I would suggest maybe ranitidine because that helps a lot in reducing the secretions. There are various studies to state that even that can be given in the subcutaneous route. Even a simple ranitidine will help. And Dr. Nayana, Dr. Urmila asks which laxative will help. If the patient is the patient on any opioid? Is this patient on any opioid? Is he on morphine or anything? No.
No, ma'am.
Well, yeah, if you're giving opioids, you can give stimulant laxative. There are different types of laxatives. You have osmotic laxative, you have stimulant laxative, you have stool softeners. So that is according to the when you do a PRE, you can know that there is having a hard stool or if the patient is having a balloony rectum. In such cases, if the patient is having a long-term problem, you can give bisacodyl, which is a stimulant laxative. Or if he's only having a heart, like heart stools, the bowel is moving regularly, then you can just go for stool softeners, like the common ones like remafin with what is the content? Liquid paraffin with milk of magnesia. That is the content of remafin. You can give that, or you can give syrup lactose, which is a stool softener. Lactose can also help. Dr. Kalyani, can you be a bit more clear with your question? Can you unmute and ask?
Hello, hello, Dr. Hashmat. Actually, no, it's not a question. I was just suggesting that since she is a stage 4 CA colon, her probably the colon is already in obstruction. If it is a chronic obstruction and she's having a difficulty in formation of stools and passing them out, so wouldn't we help her in just supplementing with a liquid diet? So there's no bulk that is produced.
I would add points to that. So Dr. Kalyani is asking, since she is having a carcinoma stage 4 CA colon, will it be advisable to give liquid diet instead of going for a solid diet to avoid the
Yeah, we
bulk.
can suggest that. Yeah, we can suggest soft food, which is very easily digestible. We'll talk a lot about intestinal obstruction in next class. Okay, our next class is about that one only. We'll deal in what to give and what not to give and all. We'll study in the next class.
Dr. Raisa, I can see that you have raised your hand. Can you unmute and ask?
Yes, ma'am. Like in case of CA esophagus and the lower part, there will be continuous vomiting. In such cases, will the pharmacological, anything, pharmacological treatment is needed or continuous aspiration is needed? RT aspiration.
You can suggest RT aspiration, but most
Because
of
in
the
such,
time, yeah, that's a very
in
good
such,
question. Very good
okay.
question. Yeah,
Okay.
sometimes some patients will not be willing for this is suggestible. Okay, we do RT insertion for said patient for decompression and all, but most of the time, most of the people will not be they'll not be in a position to like tell like you can do that. Most of them will be denying all these things. So most of the time we have to go for this pharmacological methods to comfort them. In such cases, we usually go with the steroids, which reduces at least the edema and help. And like I told, we give continuous infusions. We go when the patient is having a continuous vomiting, we go for a continuous infusion.
Okay, ma'am. But that all those things when we tried it, it was not affecting the pharmacological treatment. Only after this aspiration, it affected. So in such denying patients, like we are using only these emetics only, right?
Yeah, like that only.
Steroids also will be
We
useful.
usually go for only comfort care, and if only the patient is not responding to all these things, we go for RT insertion and all.
Okay, steroids is helpful, right? Okay.
Steroids are also helpful.
Okay.
Anywhere if there is a malignancy and if you're suspecting that the malignancy is causing a lot of inflammation, you can use steroids. That will reduce the peri-tumor edema. Okay, in intestinal obstruction also, any kind of obstruction the alimentary canal, it will reduces the peri-tumor edema and thereby improves the symptom. We cannot tell like everything will be okay, it'll be fine, nothing like that. We are just supporting them and we are making them comfortable. Putting a rice tube it is not that they'll not be comfortable. Only very few patients will agree with that.
Okay, ma'am. Thank you.
Thank you, Dr. Raisa. So there are a few more questions in the chat box. So one question from Dr. Kurt. So he has a question about dysphagia and spastic quadriplegic sleepy children coming with complaints of repeated vomiting, maybe because of their bulbar palsy. Any role of antiemetics or pharmacological methods in CP children? Dr. Nayana?
See, there are a lot of causes for vomiting. Okay, like for like when you ask for what is the cause of morning sickness like that. See, we have not discussed like briefly about everything. We have discussed a scenario we see in palliative care and the common things. So we can try antiemetics for all these kinds of patients. We can try. And the other thing, what we have to explain to the family member is that also I have mentioned in my slide that we cannot completely take out or completely cure this kind of vomiting. Okay, we should first the patient. See, the next question is if anorexia, nausea, vomiting is persistent. See, first we should be able to tell the caregiver, see, all these problems are caused by the disease, is caused by the disease which is progressing. Most of the time it will be progressing. So we'll try to reduce the symptom by giving all these drugs. We'll try to comfort. We'll not only the drug part. We can give psychologically. You can give the support. A patient who is suffering, you can acknowledge them. We know that you are suffering. Your problem. You have a lot of problem. So it is not only the pharmacological part. You can address the patient in many other in scenarios. Also, you have to make the family understand that, see, we are not going to take away or heal everything, or we are not telling that we'll be able to. Very difficult. See, nausea and vomiting, it is very difficult, like you told. Sometimes it cannot be controlled. Whatever you try everything, you will not be able to control. At least if the patient is able to sleep, or if he is comfortable for at least few hours, it will be very good. I'll tell you a story. I have seen a patient in our unit, and he was diagnosed with the CE stomach. Okay, so he was having continuous vomiting like this, and we tried all our best to give him support, like try to relieve his suffering. Even we engaged our senior doctors and everything, but he was a young man. He was merely around 40 or something. So, but we couldn't. But on the day before he died, like the previous day, we tried something. I forgot which drug we gave, and he slept for like 4 or 5 hours. The next day morning, he told he was able to sleep for 5 hours. That was a very big thing for him. So we were able to comfort him for at least 5 hours. That we were happy about that. But it is a very difficult symptom. It's not like pain or also. It is very, whatever we try, sometimes we will not be able to achieve. That you will be able to tell the caregiver that this will be there, this can be there, but we'll try our best to keep them comfortable. That's all.
Yes, that's really really true what Dr. Nayana was mentioning, because though we look into all these strategies, the pharmacological, the non-pharmacological, there are many patients that we deal with who goes in for a refractory vomiting, and it becomes really difficult for us when it becomes intractable to manage such conditions. And just to add on to that, I would say there are certain broad anti-emetic drugs like olanzapine, which acts on multiple receptors like domperidone, the H1 receptor, the muscarinic receptors, the domperidone from D1 to D4, the 5-HT3, 5-HT4. So all these receptors are being covered by the drug olanzapine, which is an atypical antipsychotic. So the last resort, maybe in a case of refractory vomiting, maybe we can try olanzapine about 2.5 milligrams to 5 milligrams Hs at the night, and it can even go up to 10 milligrams tablet for about 24 hours. So that has actually helped certain patients, but definitely we need to address all the aspects of suffering, not only the physical, but also the emotional, the social, as well as the spiritual. Because as a physicians, as palliative care professionals, we always say that we look into total suffering. So that can be many other reasons like anxiety, which is adding on to the nausea and vomiting, as Dr. Nayana was mentioning. So even benzodiazepines like lorazepam can be given at night, which actually helps with sleep as well as tries to control nausea and vomiting. So even after doing all of this, I would say, as she mentioned, there are many patients who, even in end of life, we found it very difficult to manage with intractable nausea and vomiting. And being there for them at that moment, and ensuring that you are there to comfort them always, and giving that amount of support to the family as well as to the patient helps a lot. So I think I just wanted to add that note at the end. And I think there are more questions.
Dr. Dilip has asked
Yeah.
any drug of choice. Dr. Dilip, did you mean the anticipatory vomiting? What did you mean by the phobia of vomiting? Did you mean the anticipatory vomiting caused due to
Not
anxiety?
not exactly anticipatory, but the patient has a huge phobia that undergoing treatment. So whatever the patient will eat, she will vomit. She will vomit. So in that she doesn't eat. So got a severe phobia that anything she will do, she will vomit out.
And I think we should understand what is the cause of vomiting in such case, and you can try this. Benzodiazepines will actually help. I cannot tell that this is a drug of choice for phobia of vomiting. Cannot tell. We can try. If the patient is, if you think that that may be due to the anxiety, you can try it for 2-3 days. If it is working, you can go forward with it. Otherwise, there will be some other cause. You have to find what is causing the vomiting.
Yes, so yes, in cases of, I mentioned phobia, that is fear as well as anxiety, the GABA receptors getting involved. So there you can actually try the benzodiazepines like lorazepam, and even drugs like levomethrazine might help. So that you can actually try. So in India, I think you can try with what Dr. Nayana was mentioning, the benzodiazepines like lorazepam. It can help with that kind of nausea and vomiting. And Dr. Aiza is asking, patient already on NGT will have vomiting soon after the feed. In such case, what all we should think of? So, Dr. Aiza, would you be a bit more clear about this? Like,
No, what are the causes? Sometimes, not always. Sometimes a patient used to tell whatever we give. Soon after that, what are they feeding? It will come out. So what all can cause like that? Is it because of RT tube or blow something like that?
I cannot understand that. Whenever we recently had a patient here who was on nasogastric tube, but there was no like vomiting episodes for her. I think we can try some prokinetics like metoclopramide for her. If such thing is happening, we can try. A lot of pathology when a patient is having malignancy, lot of pathologies happen there. It will not be like a particular thing causing the problem. There will be multifactorial problems. So we can only try that. We can try different methods. A patient on RT tube, you should think, we should actually think why the patient is getting vomiting. Maybe the patient is on opioids or any other cause. So we can try like this. Nothing like there is a this thing for like what hard and fast rules for everything. You can try.
yes, I think that answers most of the questions here. Any more questions from the participant side? Anybody would like to ask anything? Meanwhile, thank you, Dr. Manjusha, for bringing that wonderful case for presentation, which was targeted most towards nausea, vomiting, and constipation. Thank you for that. And it's my pleasure to thank Dr. Nayana once again for coming and taking this session for all of you. Thank you, Dr. Nayana. Anything else? If not, I think we can close the session for today. Over to you, Gayatri.
Hi all. First thing is happy Doctors Day to all doctors out here. And thank you, Dr. Naina ma'am and Dr. Hashmat ma'am for the wonderful and interactive session. Thank you all for joining and for your time. And we are looking forward to see you on the next session. Thank you all.